The goal was to give new insight in therapy myeloid neoplasm. Therapy myeloid neoplasm are rare disease. It's myeloid neoplasm occurring after treatment with chemotherapy or radiation. But if it's very rare, less than 1%, the overall survival of those patients is very bad. And it's why when you are treating a patient with a cancer with chemotherapy or radiotherapy, you always think about the risk of this kind of disease. And unfortunately, despite real improvements with the decrease of the toxicity of chemotherapy, there is still a higher risk in all cancer patients treated with chemo. Then I focus on new therapies because there is impressive efficacy of new therapies like targeted therapies as PARP inhibitor, for example, in ovarian cancer. But unfortunately, there is signal showing that there is most therapy myeloid neoplasm in those patients compared to patients not treated with the treatment. The goal is not to say that we don't have to use those treatments because the results are impressive for treating cancer patients. And it's not questionable to use this treatment. But what we have to do is maybe to help our colleague to find patients with very high risk to develop this kind of disease. And new technologies like NGS sequencing, next generation sequencing, is now available to detect some mutations that can maybe a few years after develop an acute myeloid leukemia. Then what I summarize in my talk is to show that those mutations, what we call CHIP, clonal hematopoiesis of undeterminate potential, is now recognized by the WHO 2022 classification as a pre-leukemic event. But not all mutations, not all patients with CHIP will have therapy myeloid neoplasm. Indeed, 25% of patients with cancer have CHIP. Then what are the CHIP at risk? What we think and what has been published by a lot of teams, it's when the variant allelic frequency, it's the percentage of mutated cells found in the blood of a patient is up to 10%, those patients can develop more myeloid neoplasm after treatment. It has been shown also that some mutation, like mutation in DNA repair pathway, like P53 or PP1D mutation, are at risk for developing those kind of disease. Then I focus my talk with three examples. The first one was immune checkpoint inhibitor. In melanoma patients, there is an improvement for the last 20 years of the treatment for these patients with targeted therapy and immune checkpoint inhibitors. And this improvement is confirmed in epidemiological studies, but there is no increase in MDS and ML, which is a good thing. And when you have a look to CHIP in those patients, the treatment do not modify the percentage of CHIP or the variant allelic frequency of CHIP. But it's not true for all the treatment. And for example, for PARP inhibitor, it has been shown that PARP inhibitor seems to increase the frequency and the variant allelic frequency of some mutation, especially DDR mutations, and then could explain why there is an increase in therapy myeloid neoplasm in those patients. And we presented data that we will publish soon, I think, from the French cohort of therapy myeloid neoplasm treated previously with PARP inhibitor. And unfortunately, the survival of these patients is very low, less than 10 months. When we study in multivariate analysis, we study factors who influence the overall survival of those patients. And first of all, AML patients have lower overall survival than MDS patients. and when the time of the diagnosis was at a distance from the discontinuation of the PARP inhibitor treatment, it's also negatively impacts the prognostic of those patients. Then we can think that if we do early detection, maybe we can improve the survival of those patients. And then I think detection of CHIP in those populations and in clinical trials will be interesting to do for all the future trials with this kind of treatment. And lastly, we present data in peptide radionuclide therapy in neuroendocrine tumor. A treatment which is called PRRT, peptide radionuclide therapy, is used. And unfortunately, there is a signal for more myeloid dysplastic syndrome and AML in patients treated with this treatment. And this morning, one of my colleagues presented data showing that in those patients treated with PRRT compared to patients not treated with PRRT, there is an increase in the emergence of clonal hematopoiesis, especially in TP53 and PP1D mutations, showing the importance of detection of those abnormalities in patients.